So when we look at biopsies and prepare reports, there's sometimes a need to look up information in a textbook or a journal. So the idea behind this is to have all this information available right at your desktop. And most of the sign out these days is actually electronic. So we are sitting next to a computer, which is usually sitting next to a microscope. And not only is information available readily, you can also link this information to images. For example, if a pathologist is not sure what BK virus infection looks like or mild rejection looks like, then he can just click and actually see an example or even a range of examples varying from mild to severe. So this is particularly useful to people who don't sign out biopsies every day, who may not be looking at these transplanted material every day. So when they do get one, they virtually always have to go and look at a textbook. And so it's really for them. So with this ready access of information, the hope is that they will generate a better report, a more detailed one, and that will translate to better patient care. So the T cells, their main job is to recognize antigens, HLA antigens, which are presented usually by dendritic cells, may be presented by other cells, including macrophages, including B cells. So following this initial interaction, there is a release of a variety of cytokines. The best known is IL-2. So the IL-2 results in proliferation of the T cells, and these T cells can then differentiate into various pathways. And looking at it from a very simplistic point of view, one important pathway is the differentiation to T cytotoxic T cells, which produce, for example, a protein called perforin, which literally perforates or punches holes into the target cells, which is the allograft. Another important pathway is the differentiation into what we call T helper cells. They are called T helper cells because they help B cells to produce antibody. And so that is where the link between the T cell rejection and the B cell rejection occurs. And as a matter of fact, T cells are always in the background in diseases which we label as antibody mediated injury, acute or chronic. So as I mentioned, there's a link between the T cell arm of the immunity and the antibody arm of the immunity. And as a matter of fact, to emphasize that point, lesions such as glomerulitis, such as peritubular capillaritis, if you study them by immunohistochemistry, about 30% of the cells in biopsies labeled as antibody mediated rejection are actually T cells. So what we label as antibody mediated rejection is better described as predominantly antibody mediated injury. One could make a case that there is actually no such thing as pure antibody mediated rejection. They are all accompanied by varying degrees of T cell mediated rejection. So the critical issue is, at what point do you want to give two therapies? So the role of the pathologist is to help make that assessment, that even in cases which are antibody mediated injury, is the associated T cell infiltrate negligible or is it significant? And the corollary is that if you have a person who presents as antibody mediated injury, he or she is not getting enough immunosuppression. So the first thing you should be looking at it is the cycloneurin inhibitor dose adequate, and if it's not adequate, you should bring it up as a part of the overall treatment for antibody mediated rejection. And conversely, if you have a patient with antibody mediated rejection who is not responding to plasmapheresis or IVIG or rituximab, then you should have the biopsy of that patient reviewed, and if there are significant T cell infiltrates in that biopsy, he may actually benefit from anti-thymoglobulin therapy. And there is a very widespread and somewhat unfortunate practice that whenever you have antibody, you call it antibody mediated rejection, but the fact is that in these cases antibody is playing a predominant role with an important contributory role by T cells, which tend to be forgotten. And this sort of dichotomization of rejection into antibodies and T cell does not always translate into the best possible clinical care. Pathology reports can sometimes be quite complicated. They can run several pages long, and they can have more than one diagnosis. And sometimes it's a matter of personal preference as to how those diagnoses would be listed in the report. For example, there may be a patient where the biopsy is being interpreted as diagnosis number 1 might be T cell mediated rejection, Bamfgrad 1A. A diagnosis number 2 might be severe chronic allograft nephropathy. Now, a busy nephrologist may read only the first line, for example, and say, oh yes, there's grade 1A rejection, I have to treat it. But if you were to read the second line, it's also saying there's severe chronic allograft nephropathy, which means that the kidney is close to the point where it needs replacement. And then you need to ask yourself, do I really need to hit this patient with additional immunosuppression and maybe trigger an infection or a malignancy when this kidney is almost end stage? And similarly, if I give you another example, and it's a real life example, sometimes I sign out a biopsy saying it has chronic active antibody mediated rejection, and sometimes these biopsies have fairly florid glomerulitis, peritubular capillaritis, and which calls for intervention. But sometimes the nephrologists will overinterpret the chronic part of it, and they will say, oh, this injury is chronic, maybe we should not treat it. But they miss the active part. And so the way we avoid all these miscommunications at Pittsburgh is we interact a lot. We review every biopsy together. So usually the biopsies come around 9 o'clock, and around 2 o'clock the nephrologists and the pathologists, they get together. They tell us the clinical history. We review the pathology findings with them. And so these two specialists, their interpretations are integrated into one diagnosis, and they can also see for their own eyes what exactly it is that we are talking. And that's not always, as they say, a picture is worth 1,000 words. So for example, even biopsies which are called borderline, some biopsies may have only 11% of the biopsy inflamed. Others may have 24%. As long as it's less than 25%, it's called borderline. And also the percentage involvement of inflammation in a biopsy doesn't tell you how dense the inflammation is. The inflammation could be really sparse and yet occupying 25% of the biopsy, or the inflammation could be really dense, the kind of the blue kidney, which I was mentioning yesterday, and that again is borderline. So it's very important for the nephrologist to come and see what is it that he is talking about. So an important effort these days is to make diagnosis at a very early stage. The earlier you diagnose, the less is the irreversible form of injury and the better hope there is of completely reversing the process. And not only that, the trend now is to identify people who are at risk for particular diseases even before the diseases develop. For example, you can look for genetic polymorphisms which can make people more prone or less prone to develop a rejection or develop an infection. So the whole idea is to make practice of medicine more personalized and not to have the same set of rules of immunosuppression or treatment for everybody who comes through the door. Biomarkers extend the vision of the pathologist. The classical pathology or interpretation of tissue is really based only on light microscopy. So techniques such as gene expression or proteomics profiling, they can literally make it possible to look at thousands of genes at once. And obviously the information that will be available by such intensive interrogation will be more informative. And indeed, there is always already a lot of publications which tell you that information obtained by molecular techniques is actually superior to and often really substantially complements the information that is available from classical examination of tissue biopsies. You could also use these technologies to assess the response to treatment. And if you are treating a patient with a particular antibody or a particular drug, the first response will occur at the molecular level. This will be followed by a response at the cellular level. And only then will you see changes at the tissue level. So if you examine tissue level changes, as with conventional pathology, you're going to miss a whole gamut of responses. And that's why these biomarker and molecular studies are extremely important to extend our capability of making diagnosis, assessing response to treatment, as well as determining prognosis of patients.